These figures illustrate some of the clinical prototypes that are currently under investigation in human subjects. And they all vary depending on how they choose to approach the problem of spatial specificity and how they approach the problem of the skull. On the top left is an example of a hemispheric array that is coupled to an MRI. The MRI allows the operator to be able to direct the target in real time, select and contour the ultrasound beam to the exact volume and shape that we would like the drug delivery to occur. On the top right is a system that is implanted directly past the skull, so the ultrasound can directly be delivered to the brain tissue itself. And then on the bottom is another type of transcranial transducer, but in this case it is not coupled to an MRI, therefore improving its portability, but is coupled to a neuronavigation module that is on its right, that allows it to allows the operator to move the transducer such that it could be it could target area that is desired. Here are some of the initial studies that have been done using these prototypes in various disease processes. So when we think about initially testing in clinical populations, we worry about some of the potential complications of the opening with focused ultrasound. We think about vascular damage that can result in hemorrhage in the brain, as well as vascular occlusion that can result in stroke. So initial selection of target, we would ideally try for an area that is less eloquent, such as the right frontal lobe. And this is a case in the first study over here. The right frontal lobe of patients with neurodegenerative disorders or Alzheimer's disease was selected as a proof of principle study. After targeting this area, you can see an extravasation of contrast that is quite well-defined and homogeneous, and it disappears when you image the patient again approximately 24 hours later, showing and suggesting that the blood-brain barrier permeability is recovered. On the right there, in the bottom are studies that were done in oncology patients, and in these patients, their tissue property can be quite different than patients who have relatively otherwise non-oncology disorders, and the differences may include the fact that they have vasogenic edema or ultravascularity due to the tumor itself. So you find that the contrast extravasation in these examples can look quite different than patients with Alzheimer's disease, for instance. Yet these studies show that it is in fact feasible to open the blood-brain barrier in tumor tissue and tissue around the tumor, and the patients tolerate the procedure also quite well without any serious adverse events. This slide further illustrates target selection and how that is achieved using various clinical prototypes. As I referred to earlier, the hemispheric array allows the operator to select the target in real time by acquiring MRI during the procedure itself. And it allows this device over here allows that to happen through a neuronavigation system, and the operator to manually place the transducer in different areas of the brain such that the targeting could be optimally achieved. The bottom system is again the one where the transducer is implanted potentially at the time of surgery with the tumor resection past the skull, so the ultrasound can bypass the skull bone and be applied directly into to the brain tissue itself. And in order to achieve spatial contour, we can imagine that the ultrasound target be stacked right next to each other in order to cover an area that the clinician desires. So we take example of an ALS population where the primary motor cortex is implicated in their disease. These patients underwent fMRI in order to further delineate the hand region of the primary motor cortex. And after we found these areas using functional MRI, we use the hotspots for targeting and able to show increased extravasation or increased permeability to gadolinium after sonication in an exact area of target. A similar study was done in also an eloquent area such as the hippocampus in patients with Alzheimer's disease, and we see on the middle panel a quite homogeneous appearance of gadolinium extravasation in the left hippocampus of this patient here. And what is the efficacy of focused ultrasound in terms of drug delivery? This is a difficult question to answer and really depends on the drug that we're trying to deliver or the drug of interest. But in the case of trastuzumab, which is a monoclonal antibody over 100 kilodalton in size, which is used to treat patients with HER2-positive breast cancer, we can potentially radiolabel this drug and visualize it non-invasively using SPECT studies. And this is what's done in this study, where trastuzumab was radiolabeled with indium-111. Patients before their focused ultrasound procedure underwent this radiolabel study in order to see how much of the drug is taken up in the tumor itself. This cohort of patients had breast cancer with metastasis to the brain, and you do see some drug uptake in the tumor, which is expected given the leakiness of the blood tumor barrier. However, after targeting with ultrasound, you can see the hot spot here is the area that we have targeted with ultrasound. We do see a significantly increased amount of drug uptake in the sonicated target. The conclusion of the study is that yes, focused ultrasound is able to significantly enhance drug delivery to the target. But again, how efficacious it is a question that needs to continue to be pursued in future studies, and will greatly vary depending on the tissue property itself as well as the drug of interest. This is another study that hopes to answer the same question using fluorescein. Patients with brain tumors underwent a procedure where a non-enhancing portion of their tumor was sonicated in order to open the blood-brain barrier. Fluorescein typically is used to highlight high-grade gliomas where the barrier is already leaky and is used to allow surgeons to achieve a better gross total resection of these high-grade gliomas. However, in the case of low-grade glioma or non-enhancing part of the tumor, fluorescein does not readily permeate the tissue, and by using focused ultrasound here, they're able to very well visualize fluorescein in these areas when the patients were taken for surgery after focused ultrasound. In terms of tumor response in the oncology population to focused ultrasound and treat and drug combination therapy, there is promising early data to show that there is potentially a response to treatment. However, this data is quite early and is an area that is under active investigation, and we're waiting for multi-center studies to finish recruitment and their investigation, and for their data to come out to draw a conclusion about whether focused ultrasound plus drug combination is an effective means to treat patients with brain tumors. Another potential very interesting area of using focused ultrasound is liquid biopsy. Liquid biopsy is the ability to sample a pathology through non-invasive methods such as blood collections. Typically, and this has been well established in patients with systemic tumors, where their tumor cells or tumor DNA and other biomarkers are leaked into the systemic circulation, and blood can be drawn and tested for these biomarkers for diagnosis, surveillance of disease progression, and treatment response. One of the major issues for applying this technique to brain tumors is the fact that the presence of the blood-brain barrier does prevent leaking of these compounds into the systemic circulation to some extent. So the yield of these markers is quite low in patients with brain tumors, and it is shown in previous studies. Another challenge of this technique in brain tumors such as glioblastoma, which is quite heterogeneous, is the fact that we're not able to sample different area of the tumor spatially, and they can have quite different biological characteristics. Finally, as you can imagine, liquid biopsy is not only useful for neuro-oncology, but could have its uses in patients with neurodegenerative disorders in allowing clinicians to diagnose certain pathological markers without waiting for final autopsy or brain biopsy. So this is the first study that showed that BB opening with focused ultrasound can allow an increase in brain tumor biomarkers in the blood. So in this study in rodents, GFP labeled gliomas were implanted into the rodent brain. Focused ultrasound was used to sonicate the tumor, and after which you see a significant increase in the level of GFP mRNA circulating in the blood collection. Based on this feasibility study, we tested our blood samples in patients with high-grade gliomas who underwent focused ultrasound BB opening during their chemotherapy adjuvant phase. And we found that after BB opening, there was a significant increase in cell-free DNA compared to before their procedure. In addition to cell-free DNA, there was an increase in other biomarkers such as extracellular vesicles, and the level of cfDNA increase was to some extent correlated to patients who had a disease progression, so that the level of increase was more significant in these patients than the other patients who had stable disease. These are all quite promising preliminary data, an area that is being investigated separately from drug delivery with BB opening alone. Finally, just to touch upon some other potential biological effects of focused ultrasound BB opening, we can think about how it affects patients with neurodegenerative disorders. Blood-brain barrier integrity is something of concern in patients with Alzheimer's, in that its degradation might be a potential contributor to the disease process. So in looking at how blood-brain barrier opening with focused ultrasound in a more granular level using different neuroimaging modalities could help us understand its short-term and long-term biological effects in these patients. In this study, using fMRI, we looked at how functional connectivity between the frontal and parietal networks change after blood-brain barrier opening in the frontal lobe. Here we open the blood-brain barrier in the right frontal lobe. So if we look at the right frontal parietal network, there was a significant decrease in functional connectivity between these two nodes that did recover in longer-term studies. This pattern was not observed in the contralateral side. So this study suggests that yes, blood-brain barrier opening does alter function at some level. That is an area that we need better studies to understand this. And in terms of safety, it's encouraging that the functional connectivity does recover long-term, which assures that a singular BB opening does not have any long-term untoward effect in patients with Alzheimer's. So to discuss on several future directions that this field of research is taking, we look at the fact that we need more studies to quantify the pharmacokinetics and pharmacodynamics of focused ultrasound plus drug combination therapy. And this means doing more studies where we can radio-label a drug to look at its distribution after focused ultrasound delivery, doing studies where we're measuring the drug concentration in the CSF to look at how much of the drug is getting through. And all these data will help us better understand at what concentration of, at what dose of focused ultrasound, at what dose of drug is necessary to have a biological or clinical effect. We also need to continue high quality research in the biological effect of focused ultrasound BB opening itself. And it's particularly relevant in patients with neurodegenerative disorders. We also really need to fine-tune the ultrasound parameters and the procedure, algorithms, and flow, as well as device features that will, one, improve the treatment effect, as well as the patient experience, both leading to improve adoption of the technology in the clinical field. One instance of this could be the fact that there are efforts made to in the hemispheric array device to forego the placement of stereotactic frame, which is often something hard for patients to undergo, and also to forego the fact that a hair shave needs to be performed. These are all various efforts to improve the patient experience and eventual adoption of the technology should it be shown to be effective. So in end, I'd like to take some time to review the objectives for this module. I hope that I was able to provide you with understanding of why we would like to temporarily disrupt the blood-brain barrier in order to enhance drug delivery. I hope I was able to give you a good understanding of the mechanisms and some of the determining factors of how much blood-brain barrier permeability can be achieved using focused ultrasound and factors that impact this process. We had discussed the advantages and disadvantages of focused ultrasound in comparison to traditional techniques like direct injection, as well as modification of the drug to improve its blood-brain barrier permeability. And finally, I gave you an overview of the preclinical and clinical data that currently supports this technology and the future direction of this technology in drug delivery. So again, I'd like to thank you for your time. I hope that this module was useful for you, and if you should have any questions, please feel free to email me at my email provided.